You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. In this episode, I'm joined by Dr. Anita Vanka and Dr. Rob Stern to tackle a topic that sounds mundane, but really isn't: clinical documentation in the era of OpenNotes. As patients increasingly read what we write in real time, the medical note has quietly become one of the most powerful tools we have to build trust or to undermine it. We explore how everyday language can unintentionally introduce bias, how documentation shapes downstream clinical decisions, and why note writing is now a core clinical skill, not clerical busywork. We also dig into how medical education is adapting and what this means for experienced clinicians. For healthcare system leaders and physician executives, this is a practical conversation about safety, equity, culture, and the hidden influence of words we've been using for decades. Let's plug in. Welcome, Anita Vanka and Rob Stern, to the podcast. Where do we find you both today?
I'm calling in from my office here at Beth Deaconess Medical Center in Boston.
And I am just down the road a little bit, or across the street. I'm at Brigham and Women's Hospital, two hospitals very close together.
Can you wave to each other through the window? Is it that?
It's pretty close. Rob and I often meet for lunch, like right between our hospitals.
Like a neutral zone, so to speak. Fair enough. Anita, why don't you tell us a little bit about you, what you do and how you started doing those things?
Yes, definitely. So as background, I am a hospital medicine physician here at Beth Deaconess Medical Center. I'm actually celebrating my 20th anniversary here at the BI when I came here to do my residency. I originally hail from the Midwest, where I went to both undergrad and medical school at the University of Illinois College of Medicine. And so I did my residency in internal medicine here, loved inpatient medicine and the acuity of care that we get to see on the general medical wards, loved working with the teams, so decided to go into hospital medicine. And over the last 16 years, I've kind of also really developed my career as a medical educator, both in the residency space as well as in the space with our medical students and our faculty. I've held a variety of roles in these various spaces, but most recently, I am the residency program director here at BIDMC, and I also co-direct our education fellowship for our faculty here.
All right. I'm tired. That seems like a lot. Rob, why don't you give us your background?
I am from the San Francisco Bay Area originally, but then jumped around in a lot of different places before ending up in Boston for my medical training. So I am actually trained as a hematologist oncologist. So I know most of the people listening know what that is, but just to say, it's blood and cancer medicine. I did my training here in Boston, and I'm now on faculty at Brigham and Women's Hospital and the Dana-Farber Cancer Institute, taking care of patients with blood disorders. And then relevant to our conversation today, I helped to oversee the first year clinical skills course for our medical students at Harvard Medical School. So I'm kind of in the classroom figuring out how do we take a medical student who puts their stethoscope on backwards the first day they walk in. How do I take them to the point where they can actually intelligently talk to patients, figure out what's causing chest pain, do that physical exam with the stethoscope the right way. So that's a lot of my non-clinical work.
Rob, I feel like you see me. I feel like you're looking at me with the whole stethoscope on the wrong way thing. I recall being a medical student, and this was back in the day when the first 2 years were pretty much basic science, and you hardly ever touched or talked to a patient. And the final the fourth semester, so right before we started clinicals, they would throw us into clinics with little short white coats, and they called that physical diagnosis, and we were supposed to be learning physical diagnosis. And the joke was, there was a commercial back in the day where a soap opera actor said, "I'm not a real doctor, but I play one on TV," and then proceeded to give medical advice, which was great. There was nothing wrong with that. But we would say, "I'm not a real doctor, but I play one on PD," physical diagnosis. So yeah, that's hard.
I was going to say one of my great joys on one of their first days is the students inevitably don't know they have to turn the head of the stethoscope. And so they're listening and they're listening and they're not hearing anything and they're not hearing anything and they're frustrated. And then you go over to them and you turn it 180 degrees and then they listen and they hear a heart, and the joy that you see on their face, it just makes it all worth it.
Anita, I reached out to you because you wrote an article with one of my favorite people, Liz Salmi, and among others, that talked about how to document in the age of OpenNotes. And I was fascinated and asked, hey, can we talk about this? So let's just kick off and talk about, I think most of us probably know what documentation is. We're writing progress notes. And I think we're talking mostly focused on the outpatient area, but many people maybe don't know what OpenNotes is. So tell us what OpenNotes is.
Absolutely. And I just have to start by saying Liz is definitely, I think, everyone's favorite person. How could she not be? It's truly been such an amazing journey to be able to work with her and learn from her as I've been involved with this effort. So to backtrack, OpenNotes. So first of all, just the concept of OpenNotes really started here actually at the BI back in 2012, I want to say. Dr. Tom Delbanco, who's the co-founder of OpenNotes, had this kind of vision and initiative about what would it be like to have patients read their notes in real time and be partners with their clinicians on their own medical journey. And it was a pilot implemented here where patients were given access to their notes in the outpatient setting. And through that, Tom and his colleagues, including Liz, had done a lot of work and studies showing that there was so much benefit to this. I think contrary to what many people may have feared or had reservations about, I know I did when I first heard about it, it had actually shown to help improve our partnership with patients. It had shown that patients had better understanding of what was going on with their illness, that there was better ability to carry through plans, medications, and such. And in fact, so not only did it show that, patients had better trust in their physicians and their care team by being able to be partners with them in the notes, but also the way we wrote notes was really important in building that trust and partnership. And the way we use certain words in the medical vernacular could sometimes have the unintended opposite effect of where patients could feel biased and stigmatized and such. So a lot of work was published in that space. As you know, from a more national level, I think, Tom and his colleagues succeeded in really bringing this to life for everyone, where in 2019, we had the Cures Act, where it was a federal law that mandated that every patient have access to their medical record in real time. And this included not just the progress notes or admission notes, but also other aspects of their record as well. And there are very few rare permitted exceptions, but in general, patients do have access right away. So that's kind of how we think about the concept of OpenNotes, where it started and what it ultimately led to.
Patients have always had access to their notes, but almost no one had seen notes, because to get access, you'd have to request your medical record. And usually there was a charge because the paper was involved. But now it's kind of just out there for most of us. We can see our notes. So Rob, you're involved with first year medical student training. I recall mine, which was, or actually probably wasn't first year, it was probably third year. Hey, there's this thing called a SOAP note. And they told me what that stood for and threw me to the wolves. So I'm assuming now that it's a little bit different.
Yes, so medical education, we'll say, has become more regimented in terms of bringing clinical skills teaching much earlier in training. As the movement in medical schools have been to get students into clinical spaces earlier, there's a recognition that if you're going to get them into clinical spaces earlier, you also have to teach clinical skills earlier. And it's still variable from school to school, but generally students are being exposed to clinical skills teaching at a much earlier stage of training than they were before. And historically, as we've started to teach more than just, hey, here's a SOAP note, not having any idea what that means beyond what you use to kind of wash your face in the morning. The idea was we were teaching students to write notes for basically two purposes, and then kind of mentioning a third, but avoiding it. So one was notes were written as a way of communicating to other providers. Two, notes were written as a way of communicating to your future self. So what was I thinking at the time I wrote this when I then go back and see the patient 6 months from now, 9 months from now? And then third, and we've kind of avoided talking about this, notes were being written for billing. But no one really wanted to talk about that third piece. And so we were teaching students to write very detailed histories of present illness. We were teaching them to put a lot of information, especially in the HEMONC space. For example, for our HEMONC fellows, we were teaching them talk a lot about papers and survival data and all of this information, life expectancy. With the advent of OpenNotes, what we realized is there's now this fourth really important purpose for notes in this new audience, which was the patient. We now had to write a note that not only accounted to other providers, not only spoke to our future self, not only met billing requirements, but also was going to be readable and build patient relationships as opposed to hurt patient relationships. And so we said, how do we take what we are already teaching students? We have a rubric for students submit their note and they get feedback. How do we incorporate that patient-centered aspect to how we teach notes? Because they're going to be doing this, whether we like it or not. This is the world our students are going into. So how do we prepare them for that world?
I'm continually impressed about how we've moved forward. Let me in detail talk about all of the feedback I got on my progress notes. I never got feedback, and my notes. I recall writing a very long, it was like 2.5 page note back in the paper days in the ICU for a patient, and it was very detailed. And you could read it, and it would actually say nothing because I didn't know what was important, so I just threw everything in the kitchen sink. So kudos to you both and medical education in general that we're moving in the right direction to get to kind of focus on those things. Let me call out one thing that you would mention is, hey, so we have a new audience because of OpenNotes and because of certain laws, and that is the patient. They're much more likely to see it, and you had said we want to minimize the potential harms. And so, Anita, what are some of those harms that Rob was talking about?
Great question. And this has really been described well by several colleagues who've worked with Tom Delbanco in this area. And we can see that patients, depending on the words used or the phrases or the language used, that patients can feel stigmatized, biased, feel like they're being questioned by their clinician when in fact that may not be the case. And then, so that's one harm, like in the moment. And then it can perpetuate forward, right? So we can see that bias can continue to be transmitted through the medical record, impacting future care of that patient, whether it's by the same clinician or others. And there have been several studies showing that not only can it impact how we may perceive the patient, it can actually impact our clinical decision-making and the actual appropriate care of the patient. There was actually one study in which the authors had taken a case vignette written about a patient presenting in a sickle cell crisis and had written it in 2 different ways and had residents and medical students who read both notes. And when they assessed their perceptions, they found that those who got the vignette that was probably written in a way that we're more accustomed to seeing, but it contained many words that really we know can perpetuate bias and stigma such that patients were perceived in a more negative light, and they were more likely to not get the appropriate pain management or care. And then we also know, we know this very well, that there is a lot of racial bias in medicine. There's a lot of systemic racism, and how we think about writing notes can continue to perpetuate those same biases as well. So a lot of harms, unfortunately.
Can we just, for fun, talk about some of these words? I'll throw out one, and Rob, tell me what you think. Non-compliant.
Common. We see this a lot. So what is a non-compliant patient? A non-compliant patient is we as the healthcare provider having the right answer and a patient not doing what we tell them they should do, right? Like the idea of non-compliant is we gave you all of the tools, we gave you what you're supposed to be doing, and you chose not to do it, right? It creates this dynamic where, one, we are all knowing as physicians, and that obviously what we said is what the patient should be doing. And 2, the patient, it is then they're failing for not complying with what we're saying. I'm taking this. I know this is not exactly what people mean when they say it, but you can imagine a patient hasn't lived in our medical language for years and years. When we write non-compliant, that's how they may be writing it. And so I think that what we have to do when we're thinking about our words is forget ourselves for a minute. Forget what we intended. Forget what we've lived now for many years being in this world, and come to it fresh and imagine yourself looking at that word. If I'm non-compliant as a patient, you're making a judgment about me. It doesn't get into the fact that, you know what, maybe I couldn't afford to pick up that medicine. Maybe I couldn't go to that appointment because I had no one else to pick my daughter up from school. And there was just no way I could get to the doctor's office, right? It paints everything with a single brush and doesn't allow for all of the complexities that can go into patient behavior.
It's funny because those were words, that word specifically was one that I was kind of trained to use. Patient didn't do what we recommended that they do, so they are now non-compliant. Another word that I think has a charge that maybe people don't think about is the word deny. And it kind of implies like, well, they're saying that, they said that, but I'm not 100% sure that's accurate.
Right. And I think one thing to also think about is compare how we were taught to write the subjective to how we write the objective. Even just the labeling of that is interesting, right? Like we call the objective part of the note our physical exam findings versus what the patient is telling us as subjective when it's actually their facts, right? It's their story. It's what they're experiencing. So we would never write, I deny hearing a murmur, right? There's no murmur on exam. So why do we need to write that the patient denies a fever, chills, whatever it is? Instead, just say patient had no fever or, patient is without pain.
The one that we think about, we don't even think twice about is chief complaint, right? What is a complaint? Like, are we saying that when a patient comes in and tells us they have a chest pain, like it's a complaint that they have? I mean, it is a symptom they're having, but by labeling it their chief complaint, just think about for a patient what that means.
Yeah. Well, that's like a core part of being a doctor is taking what is the chief complaint, right? You're not, and it's again, it gets back to our healthcare system, and I'm putting system in air quotes here, that we deal with illness. We're not so good at dealing with wellness. And that's one of the signs right there, right? If you're coming to see me or we're having a conversation, clearly you have a complaint. Otherwise, we would never need to talk to one another.
But it's interesting how it started by using that word complaint, which is what we were all taught, rather than just saying concern. I'm coming to you because I'm concerned.
Yeah. Well, we've been kind of bouncing around and teasing this article that you wrote, Anita, and that Rob, I know you kind of support. So what are some of those things? There are 10 guidelines ranging from person first language. I want to dig into that a little bit, and avoid abbreviations and acronyms. Just two things. Can we talk about some of those and some of the other ones that you think are important that you discovered?
Sure. So I think number one, with the using person first language, it really gets at really understanding that your patient is a person, that they're defined by who they are, not just by their condition or by their chief concern or their symptoms that they're presenting with. I think all of us here, the three of us, have trained at a time where we refer to patients as like, go see the diabetic in room 15, or my favorite, vasculopath. They must be such a vasculopath, right? Which if you think about it, like how that sounds, like it's referring to someone who has a lot of vascular disease risk factors. But when we use language like that, first of all, it's very dehumanizing to that individual. I think we don't do it with malintent. I think we do it because that allows us to have some distance from the emotion of it, which can be very challenging, I think, when we're caring for patients and such. But what happens then is I think you run the risk of not seeing them as a person. So what we teach our students, or when we think about these best practices, is really referring to who this individual is as a person. So this is a 43-year-old person, 43-year-old woman, 43-year-old man who has diabetes, rather than this is a 43-year-old diabetic. I do want to say, in that study, when we did these focus groups with patients and such, that we did learn that there are some individuals who do prefer to be kind of identified or labeled by their condition predominantly and from the community they're from. So that's important to them. And I think it goes to the second principle of referring to your patient as they want to be called. So we know medical vernacular, it's like you're almost being, when you start practicing in the clinical sphere, it's like you're being indoctrinated into the secret language of medicine. And I remember when I used to co-direct this course with Rob and teaching medical students, like they would always be asking, well, what is that abbreviation? What does that mean? And I would even forget, when did I actually learn to abbreviate something this way? It just happens, right? That language. And I think it happens out of probably convenience. We're all pressed for time and using shorthand, and we just develop this code to speak. I think it allows us to also distance ourselves from some of the moments that can be really tough when you're caring for people. But what happens is when you pepper your notes with abbreviations and acronyms is, first of all, it can be actually confusing to yourself when you go back to look at this note. It can be confusing to your fellow clinicians if they're not using the same abbreviations or acronyms. And it can be really confusing and hard for your patients to see. There was an editorial written not that long ago about a patient seeing the word SOB or the acronym SOB peppered all over their notes, right? And in medicine, we use that very commonly to mean shortness of breath. But to someone who's not in medicine, that can be quite jarring to see because you don't actually understand what that means. As much as that is a best practice that we've defined and hear from patients and others, it's probably the hardest one, I think, to implement because of the shorthand we use when we're writing notes all the time.
In healthcare technology world, we still do. We have computers that we put on wheels on a cart and move it around. And oftentimes we would refer to those amongst ourselves as a computer on wheels or a cow.
Cow, yes. Yes.
A cow, yeah. So there's or at least in my world, it was a famous revelation that a patient got very offended because she overheard two nurses talking, and one of them said, well, there's a cow over in room 7. And she thought they were referring to her. In fact, they were referring to the computer on wheels. At that hospital, at least, we started calling it something else.
Yeah, we call it WOWs now.
WOWs or the computer is another way.
Why don't we just call it what it should be called?
Because we're in medicine, and it's with all the kind of using the abbreviations or using big words. Sometimes we go the other way, right? I like tachycardia. That's one of my favorite words, but in fact, it's just high heart rate. We're a profession, and we're not much different. I am saying, though, that a lot of professions do have these abbreviations or use these very precise terms with the work that they do. And sometimes we kind of just assume that. And again, 20 years ago, no one was reading our notes besides us.
One of the things that I think you bring up, Craig, there, and Anita and I talk about this a lot when we're working with students, when we're working with faculty, is we still make mistakes around this. Right? We will still accidentally embed the word tachycardia in our plan that we're writing for the patient to read. So, as we talk about these best practices, it's not to say that we've mastered this. This is we're all learning, and it's breaking habits that we all have. Even for Anita and I, who are supposed to be quote unquote experts at this, we are constantly breaking our own bad habits. So I just want to call that out of this is a work in progress.
Rob, are there any other kind of recommendations from Anita's paper that you wanted to highlight?
So there's a bunch. One of them that really rings true for me, especially in my world as a hematologist oncologist, is say what you write and write what you say. So the idea here is that a patient is going to go home and they or a loved one may open this up and read through your assessment plan. And the first time that they know you might be thinking about cancer as a cause for their weight loss or their low white blood cell count or their cough should not be when they read their note. That is how you're going to, one, cause fear. It's going to cause patients not to come back to see you. So write what you say what you write. If you're worried about something, if it's going to go into your note, it's got to be talked about in the room. The first time a patient should be finding out about something is not when they're reading their note. So that's one. Second is keep physical exam descriptions objective. And I think for me, this really kind of hit home on a personal level, which was my amazing mom, who is in her early 70s, had a cold and she was having some difficulty hearing afterwards. And she went and saw an ear, nose, and throat doctor who was focused on her hearing. And she said it was a fine visit. Nothing amazing, but nothing that really bothered me. And then she opened up his note when she got home. And the first thing she read is, "This is an obese older woman." No, not go over well. And my mom is a beautiful, wonderful person, but this is something that plays on insecurities she's had. And any trust that provider may have built, gone in 4 words. And for what? Why, for someone who was listening, assessing her ear, did that need to be the first line of the physical exam? But just really think about, why am I putting this in? Is this building patient rapport? Is this a necessary statement? So that's keep the physical exam objective. And then empower your patients with encouraging words and clear next choices. So we talked about language around non-compliant, denies, chief complaint. That's one side of the coin. The other side of the coin is when you're writing your assessment plan, think about, if I'm a patient reading this, is the language that's going into my recommendations for testing, recommendations for lifestyle changes, medication use, are those ones that a patient's going to read and is going to encourage them to carry out? I'm a medicine doctor. I am only as good as a patient is willing to do what I recommend. I'm not opening up their body. I'm not correcting something in an OR. So for a patient to be willing to take the medicine I recommend, make the lifestyle changes, do the lab test, they have to trust that it's the right thing to do, and they have to have buy-in. And so I think about my assessment plan as a way to build that buy-in, because if I can, they're much more likely to carry through what I recommended.
We've hit a bunch of the kind of recommendations. Let me take us completely off track and say to Anita, it doesn't matter anyway. It doesn't matter anyway, because all of us are going to be.
The podcast is over then, Craig.
No, that's not why. That's not why. This podcast, we're going strong, Anita. It doesn't matter, some might say, because, hey, we're moving to these AI scribes, where, especially in the outpatient setting, there'll be a microphone, or some people call it a phone at this point, that records our conversation and then generates a note for us to look at and, of course, and approve and edit if need be. But boy, oh boy, they're getting good. And so if I'm just going to have an LLM or an AI write my note for me, because and there's many benefits to that, of course, then talking about all of these things seems less important. What would you say to that statement?
That is a great question. And I think, we hear that a lot with many things in medicine and other in other professions these days. But I would say the opposite is actually still holds true, that we have to know those best practices and know what we're doing. And for a couple of reasons. One is, we do see AI and LLM being incorporated into so many different uses in medicine and just the world in general. And actually here at the BI and some of our ambulatory clinics, the Heidi AI is being piloted in several ambulatory clinics. But, the large language models are only as good as we train them, right? So you still have to have that intentionality of what you feel should be in the note to build that partnership and trust with your patient. We know that AIs can hallucinate. And so it is important that we know what we're doing so that we use AI effectively to kind of be a partner with us in upholding these best practices and such. And then secondly, I would say is when we are teaching learners aren't going to be using AI from the get-go. I hope not. Yeah. And I hope it's really important that they learn how and think for themselves on how to be doing all of this, and then learn how to incorporate AI effectively into their practice and such. But, medical students, when they're first learning how to write notes and such, I would hope that we're not using AI from the get-go. So it's still important for the faculty member and for the teachers to be intentional about what we're sharing with the medical students and why, and upholding those practices. So I would say for all of those reasons, all the AIs in the world would be really helpful. And I think it can have a great use, especially with the abbreviations and acronyms, part of the best practices that we struggle with a lot. But I think it's still incumbent upon us to be intentional about this and to understand why these best practices are so important.
I'll just add, Anita, this is embedded in what you said, but even if an AI is generating my note, that note still represents me as the physician with the relationship with the patient. And maybe at the bottom of my note, it will say, this was generated with an AI product. But when the patient reads that, they're still looking for my words. They're still looking for my thoughts, my recommendations. And it's not a get out of jail free card. It's not if the AI says something that upsets the relationship with the patient that I could just say, oh, AI said that. I have no part in that, right? No matter who's generating the note, we are still responsible, and we are at the least the editors of the note. And it is incumbent on us for the notes to build relationship, not hurt relationship. And again, whether AI is generating it, we still have to play that integral role in the note itself.
Both of you make an excellent point that these large language models are trained on the very notes that we've been producing for decades and decades and decades. And so they're going to need some new instruction. And the physical exam, of course, is something that, as you've already described, there are kind of ways of recording the physical exam, and oftentimes those are the AI does not know what you're examining or seeing, so you're going to be talking about that in the middle of doing it, and so you can kind of make your life much easier. All right, I was worried there. I was worried after we had this long conversation that there would be no need for it because it didn't matter anyway. It still matters, and it's always going to be your note, and you're the one that's going to have the responsibility to make sure that it's accurate and that it's appropriate. So we've established that there's a problem. We understand what the problem is. We kind of understand some of the steps to solving it. What about the old folks, such as myself, who've been doing this for a long time? How do you get the message out to them that, hey, when they started, patients weren't looking at their notes. There was no concept of OpenNotes. How does that information get to them? Have you gotten any feedback from your colleagues, either positive or negative, with respect to kind of hearing some of these findings? We'll start with you, Anita.
Definitely. I think it's just as important to have kind of a formal education of our faculty, if not more so than our learners. I think what Rob and I found in our first year of doing this curriculum is the medical students who are literally maybe a week or two into being medical students, their reaction was, well, of course you wouldn't say complain. Why would you say complain? Of course you wouldn't say deny. Why would you? And because they were coming in with that experience of not having been indoctrinated into the vernacular yet, they were coming in as former patients or loved ones of patients, having read notes and understanding the impact of that. And then we held a similar session with our students' preceptors in that first year, the faculty, and the discussion was much more robust because it was literally undoing kind of these years of practice where everyone have been writing notes in a certain way without any malintent, but also now learning that unfortunately there is a negative impact when you do write your notes in a certain way. And I think that was really important for people to learn and just kind of sit with and discuss how can you phrase your notes a bit better. And we found also that it is important to be intentional about teaching kind of the above layers, like the teaching the teachers, because what we can see happens, as you well know, is you teach one thing in the classroom. And then when your students or your young physicians enter the workplace, we have something called the hidden curriculum, right? Where they start to, their practices, they start to undo what they've learned because they see their residents or their attendings and their faculty doing it in a different way. So a lot of the teaching that needs to also happen from the top down is important so that you don't lose what you've taught in the classroom space and lose that to what we call the hidden curriculum.
And Craig, I can build on that just to say, what's been really interesting is that Anita and I started this at the medical student level, but as faculty would come who teach medical students, they would say, we're being asked to write notes like this, but no one's ever come talk to us about how to do it. We've never heard of best practices around this. And so we've started to be invited to not to teach this to students, but to teach this in grand round settings to faculty. And one of the things that kind of has dawned on both Anita and I is, and this is maybe speaking to people who are listening to this who are chairs of medicine, plan conferences, in hospital leadership positions. We think about continuing medical education a lot around pathophysiologic knowledge acquisition. We think about it as we need to learn the new drugs for diabetes. We need to understand the new pathways that are affecting LDL buildup. But we don't think as much about, are we continuing to teach evolving clinical skills? Are we teaching our physicians, our NPs, our PAs, our faculty more generally, the evolution of how we take care of patients in regards to our clinical skills? And so I would say this is a great topic for a faculty development session. This is a great topic for a grand rounds. And because Anita is so good, what the feedback we've gotten when we've done this in a grand round setting is faculty say, this is one of the most tangible, practical grand rounds I've left, because it's really not pie in the sky. It's not conceptual. It's really getting into the nitty gritty. And they'll bring us notes. They'll say, hey, I saw this patient a week ago. I didn't know how to phrase this. Can we talk it through? And so just to get really nitty gritty, get practical, think about clinical skills as a continuing education piece.
Love it. I love it. And I'm glad to hear. I was a little fearful that you were going to say people told you to go away. But you generally didn't get that response. We've been talking for a while about designing notes. That's really what we've been talking about. I like to always ask the same question at the end of all of the podcasts, which is, are there other things that are designed so well besides notes in your life that they bring you joy? So we'll start with Dr. Vanka first. Is there something that's so well designed it makes you happy whenever you interact with it?
Yes. And I promise I'm not being sponsored by Amazon to say so, but I love my Kindle. I'm an avid reader. I cannot tell you over the years how many physical books I've collected over time and how I've run out of space for them and how many we have to donate on a yearly basis. So ever since I've had my Kindle, whether it's the app on my phone or the actual Kindle, like the number of books that I can carry, and it's portable. It's easy. I love it. I will say I do miss the physical books at times. And there are times when I will actually, if I really like the book, go get the physical and just so I could have it. But for the most part, it's saved a lot of room on our bookshelves at home.
That's awesome. No one's ever said that before. Is there a particular version that you like of the physical device?
Yeah, the one that I have right now is the paperweight, which I got a couple of years ago, and I keep having to stop myself from upgrading because just to have something new and shiny, I really don't. But the paperweight's great. It's very light. You can read out in the sunlight, and it doesn't, you're not blinded by the lights. It's very easy to use and carry around.
Excellent, Dr. Stern.
Yeah, so I thought about this question a lot, and I threw it out to some friends. I thought about my tennis racket. Some friends said a pizza cutter. Another friend said pizza itself. But I'm going to go really, really like medical nerdy here. And if I'm being truthfully honest, the thing as a hematologist that I keep coming back to that I'm always in awe is the platelet.
The platelet.
The blood cell. The blood cell, this small blood cell, no DNA, no nucleus, yet it changes shape when you need it to change shape to stop bleeding. It releases its own mechanisms, both to clot, but then to not clot. We're finding out it's integral in cancer metastases and prevention of it. I can keep going, but like, what an amazing little thing.
I am so glad that you asked me first, Craig. I don't think I could have followed up Rob's The Platelet by the Kindle.
Both of you gave really good answers. Okay, I've been doing this for a while now. Those are both very good answers. I would not have predicted platelet. Well, I want to thank both of you. This was a great conversation. Really appreciate it. I certainly learned a lot, and I think the audience learned a lot as well, and look forward to seeing how the education kind of makes its way through, not only for our young physicians, but for let's just say, I was going to say old, but more mature physicians. Thanks again for being on the pod.
Thank you so much for having us. This was so much fun to chat with you and spend the time with you. Thank you.
And we should just say, if people want to reach out to us, reach out to us. We love talking about this. I clearly can talk forever. So be in touch with questions, be in touch with thoughts, arguments.
If I can find your email address, then most normal humans can do it. Thanks again.
Thank you so much.
Thanks, Craig.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Anita and Rob, follow them on LinkedIn. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.